Good morning. This is Senate Health and Welfare. It is February 23rd, 2022. And this morning we're looking at the Interstate Compact for Child Placement Bill. And then we'll also be moving on to a draft of S85 and a couple of other bills that we've been working on, S206 and S90. So thank you all for being here at 8:30, and good morning to Patricia and Deputy Commissioner Radke. Will you be testifying together on the bill? I think it's S72, isn't it?
Yes, it is. I would be just doing some brief comments and then turning it over to Tracy, who's our subject matter expert. I'm having some trouble with my video. I can't turn it on, unfortunately. I apologize for that.
Well, it may actually be helpful to your to allow us to hear you. Sometimes the video gets in the way of the audio, but we completely understand. So why don't you go right ahead with your comments, and then Tracy can go ahead with her presentation.
Will do. Well, good morning, Chairwoman Lyons and members of the committee. For the record, my name is Erica Radke, and I'm Deputy Commissioner of the Family Services Division of DCF. I'd like to thank all of you for the opportunity to discuss Senate Bill 72 regarding adopting the new Interstate Compact on the Placement of Children, also known as the ICPC. DCF is in support of the new compact because it will encourage more uniform and improved practices when children are to be placed across state lines. And with that said, I'll turn things over to Tracy Casanova, as I said, who is our subject matter expert on ICPC, and the Deputy Compact Administrator for FSD, who has a presentation detailing the new compact. Tracy, take it away.
Thank you. So I am Tracy Casanova. I'm the Deputy Compact Administrator for the Interstate Compact on the Placement of Children and Commission on Juveniles, and I'm also the Human Trafficking Consultant for our division. Do you guys have a copy of my presentation, or will you need me to share my screen?
We have it right in front of us. We actually do like looking at a shared screen, and there's so few of us, it works out. If you don't mind doing that. And then as you're going through, would you like to have questions on the spot or wait until you've completed?
If questions can be held to the end, I think that would be helpful.
Okay, we'll do that.
Okay.
Unless it's a question of understanding, clarification.
Right.
Yeah. Okay.
So let me share my screen one moment. So just bear with me while I get the presentation. Okay, can everybody see my screen with the presentation?
We have your note page as well. I'm wondering if you can just put full screen.
Oh, I know. Okay, I know what happened.
Yeah.
1 second. How about now?
Okay. And just so you know, we are totally crunched for time. So if we should have a hard stop at 9, and we'll have you back in as time going forward. So thank you.
Thank you. So I will, I don't think I'll need all of the time, but please, I look forward to hearing all your questions once I'm done the presentation. So I'm here to talk to you about the new compact and the differences between the current compact and the one that's been proposed. And okay, So to start off with, I just want to start off by explaining what the ICPC is. The Interstate Compact on the Placement of Children. It's state law in 50 states and then District of Columbia and in some of the US territories. Failure to comply with the law can result in federal sanctions against the state. ICPC applies to foster care, kinship care, which is in the state of Vermont, always licensed, but it's not always in other states. It includes parental care, conditional custody orders, residential care, and adoption, which are private or public. ICPC provides the ability for us to request a home study on parents, kin, and fictive and adoptive families residing in other states, and it also allows us to request supervision by that state's child protection system, if provided that the placement has been approved. The way that the compact works is that, for example, if we have a child here in Vermont who we want to place in another state, the other state would be the receiving state. They're the ones who are going to determine whether or not the placement can be made. And as the sending state, we would be the ones to determine whether or not we would want to place that child in that approved placement. According to the Adoption and Foster Care Analysis reporting, in 2015, there were 428,000 children placed in foster care nationwide. This was an increase from 2010, when there was approximately 400,000 children in foster care. It is anticipated with the opioid epidemic an increase since 2015. In 2003, 5.5% of children in foster care were in interstate placements. 40% of those were children placed with relatives. And here's some Vermont data. So in 2020, the Vermont Interstate Office, which is me, processed 446 interstate requests. And the breakdowns of those requests were between home studies, incoming and outgoing requests, residential requests, private adoptions. We placed 145 children out of state, and 50 children were placed into the state of Vermont through the compact. So why do we need a compact? Why is this important to us? So here in Vermont, we value placing children with kin. And as the number of children in DCF custody rises, we need the compact in order to facilitate their placement with these kin in other states. The compact allows us to provide services to families who reside in out of state. And most importantly, it allows us to assess their suitability for placement. We, as in Vermont and in any part of the country, we can't send our workers to other states to assess the suitability of homes in other states. Our jurisdiction ends at the Vermont border, and in most states, there are statutes prohibiting the practice of social work in other states. So the current compact was adopted in 1960, and while it's been in effect for over 50 years, it's extremely outdated. Its governing process and structure need to be updated so that we can ensure timely placements of children across state lines. The new compact is going to remove or reduce barriers to timely placements across state lines, and it's going to ensure that children are afforded the same protections and services as children placed within a state. Currently, existing laws don't provide enough protection because each state's jurisdiction ends at their border, and the necessary protections that are needed cannot be compelled for children once you leave your state. So in 2004, the American Public Human Services Association, APHSA, and AAICPC convened a task force to authorize the rewriting of the ICPC. It was agreed that there was a need for a solid legal foundation for interstate placements was critically needed to ensure timely placement of children. So the Vermont Attorney General's office was one of the stakeholders that was part of the team that was used to draft the new compact that is sitting in front of you today. Also included in that stakeholders group was the National Child Welfare Directors, the Department for Health and Human Services, the Administration for Children and Families, the Children's Bureau, the ICPC administrators, and the National Council for Juvenile and Family Court Judges. So how we got here today is in 2018, the president of the Conference of Chief Justices sent a letter to all of the governors requesting that the new ICPC be adopted, as the Chief Justices believed it would help speed up timely placements of children in other states. Why does Vermont need to be an early adopter? And one of the most important reasons that Vermont needs to be an early adopter is that the first 35 states who adopt the compact get to be the states that create the rules as to how the compact is going to work and how it's going to be regulated. Currently, only 13 states have signed on so far. And if we were to sign on, we would be at this time, we would be the 14th state. The state of New Hampshire is also taking it up on with their legislator this session. In 2020, the New England Regional Opioid Initiative Leadership Committee also sent a letter to Chief Justice Reiber from the Vermont Supreme Court, urging him to support the passage of the new compact. We have support from Lund and private and independent attorneys. We also have support of some of our private residential programs who take children from other states that are not involved with juvenile justice and child protection. The new compact is going to standardize the practices across the country, and there will be enforcement measures should the compact be violated. So I'm going to outline some of the main highlighted differences between the current compact and the new compact. So the new compact is going to update the legal framework to address the human services and needs and infrastructure for servicing children and families in the 21st century. So we won't need to come back to have it updated in another 50 years. The way the new one is written is going to allow us to change it as the times change. The new compact is also going to create one home study template that will be used by all jurisdictions. Right now, every state and even within some states use multiple different home study templates, which also leads to timeliness of the completion of the home study and a decision in terms of whether or not that child can be placed in that other state. The new compact is going to increase timely placements in other states with having one home study template. It's going to clarify the applicability to the non-custodial parents, and it's going to provide administrative review of denials in the receiving state. There will be enforcement measures added to the compact, and the new compact is because of it, it will strengthen its enforcements, and the rules can be changed more frequently, and that will make the compact easier to remain current. So currently, the ICPC applies to parents, to everybody who wants to place their child in a residential program, even if they're not involved with child welfare or juvenile justice. And those parents need to seek ICPC approval prior to their child being placed in an out-of-state residential treatment facility. The new compact will not have that same requirement. It's not going to apply to parents. All that will be required is a notification that that child has been placed in the other state. That will speed up the ability for children to access treatment in other states. Oops, I went too fast, sorry. The new compact is also going to clarify when ICPC applies to non-custodial parents. Currently, multiple states have different interpretations and Supreme Court rulings regarding the applicability of ICPC with regards to placement of a child with their non-custodial parent when a dependency proceeding is taking place. The new compact is going to move the information about the applicability of ICPC to non-custodial parents into the articles of organization, which will be adopted by all states. It's going to streamline and clarify when the placement with an out-of-state non-custodial parent can be made in the context of a dependency proceeding. And so for these purposes, dependency proceedings are here in Vermont, are CHINS proceedings. It's also going to distinguish the difference between an assessment and a home study. So an assessment is the evaluation of a prospective placement by a public child placement agency to determine whether or not that placement can meet the individual needs of the child. And a home study is going to evaluate the actual placement in the home to determine whether or not it meets the standards and the requirements in that state where that family is located. The new compact is going to provide and require administrative reviews. The old compact doesn't require or provide an appeal process or an administrative review process for denials. For example, here in the state of Vermont, we do not have an appeal process for my decisions. Any ICPC decision that I make is final. The new compact can provide an administrative review of the receiving state denial of a placement it's to be conducted in the receiving state pursuant to the Administrative Procedures Act. In terms of the rulemaking, the current rules and regulations are promulgated at the AAICPC annual business meeting. It's going to have one vote per state and no opportunity for public input or comment. The new compact is going to have, similarly, it's going to create a one state, one body vote to make rules and regulations and signatories, and it's going to provide opportunities for public comment and input. The rules promulgated by the Interstate Commission shall have the force and effect of administrative rules and shall be binding in the compacting states to the extent and manner provided in the compact. This will create enforcement, and it will provide mediation and binding dispute resolution, remedial training, and specific technical assistance. So what are the next steps? So the next step here is that we need to pass S72, which is the language for the new compact. Once this bill is passed, we will need to wait for at least 35 states to sign on before the bill can come into effect. Once 35 states have adopted the compact, the rulemaking process begins and is anticipated to take about 12 months. We want to be one of the first 35 states so that we have an equal voice at the table during the rulemaking process. An important thing to note is that when this new compact is adopted, we cannot strike the old compact. We will need to have the old compact remain in law for now until the new compact is in effect, and that won't happen until the 35 states have adopted it and it goes and the rulemaking process is complete. And that completes my presentation. Does anybody have any questions?
Yes. Okay. Why don't we take the slides down? And thank you for that. I noticed on the other sheet that you sent in that at the end, you do have some of the data that you mentioned, the national data. And any of that information will be very helpful to us. I think the number that you gave us was 428,000 nationwide, and the other sheet says slightly more. So I don't know where the difference is, but anyway, I do have a couple of questions, and then I know the committee will have questions. So I guess the first question is overall, how is this? I understand what you have said, but how is this an improvement? And how will this benefit the state and the kids who are seeking placement?
I think the most important thing is the timely placements of children across state lines, because every state is operating using a different home study template, and there's very minimal enforcement mechanisms involved right now. We can send a request out for a home study, and right now the ICPC states that home studies are to be completed within 60 days. But it can, depending on what part of the country you send the home study request to, that can take anywhere realistically from 90 days to 12 months. And that means 12 months, up to 12 months of that child not being able to be placed with a relative and might be in stranger care during that time. So for me, that is the most important reason why this compact needs to be adopted. And it, because it's going to speed up the ability for children in foster care to be placed with family members. The other part of it is it's going to create uniformity to the home study template, and it's going to create uniformity regarding the applicability of the compact to non-custodial parents. Right now, there are multiple Supreme Court rulings across the country with different interpretations of the compact, and this is going to it's going to clean it up, which it desperately needs.
Right. So that was actually, I was going to ask a question about the courts and how many of the placements that we currently have are related to a TPI or a court, termination of parental involvement.
TPR.
Thank you, TPR.
So I don't have that data in terms of the number of children placed right now. The data I can request that, but I'll have to ask the company that we contract with for our case management system to break it apart, because I don't have the ability to break apart the types of adoption cases that I have right now open. What I can
Okay.
tell you is that there's a good chunk of children that we place in other states prior to a termination of parental rights. And once a TPR has happened, then we submit a request for adoption. So the majority of those kids who are being adopted in other states through child protection were already placed there prior to the termination proceedings.
Okay, and in your work, do you work closely with the CHINS proceedings that are going on? And I know there's a whole CHINS process that's going on now. So are you a part of that process?
I am asked to come in at times to provide technical assistance to the courts and to the parties to provide explanation about the compact and the rules around it.
Okay.
And to provide updates. So I have,
Okay.
So I can come anytime anybody asks in order to provide assistance.
Okay. Yeah, it would seem to me important in terms of placement when decisions are being made. Yeah.
Right.
So, and then you've mentioned enforcement a couple of times. Can you just elaborate a little bit on how an enforcement proceeding would take place? What do we have now, and what will this do differently?
So I can give you an example. So the other compact that I oversee is the Interstate Commission on Juveniles. And 10 years ago, we adopted the new compact for the ICJ, the Interstate Commission on Juveniles. And part of their enforcement mechanisms are very similar to what's being proposed to ICPC. But in addition to the mediation and dispute binding resolution, there's also sanctions that could be imposed on states for violation of the compact. And I have to tell you that it is a motivating factor for compact administrators to make sure that the things continue to happen in a timely manner when there's a level of accountability. And there's just not that same level of accountability with the current compact and the way that it's structured. And so I do think having accountability for states will help speed up the time, also speed up the timeliness. And I think having right now, each state has the discretion to approve and deny things. There's really no rules in the ICPC that dictate the boundaries of denials. It's solely to the discretion of an administrator. And that varies across the entire country as to why they could be denying something. And in some states, there is no appeal process, like here in Vermont. So I think those are some of the examples of enforcement, as well as creating some uniformity to some processes, which will create consistency across the country, which is important.
Okay, thank you. Questions, committee? We're bumping up against our time, but I think this is important. And we, as I said, we'll come back to this as needed. Senator Hardy.
Thank you, Madam Chair. Thank you, Ms. Casanova. That was a really helpful presentation. I'm curious about the timeline. I'm just a little confused, and I'm wondering if the dates are just old because this has been in the works for a long time, because you said 50 years, but it's really 60 years, more than 60 years. And then there's a date of 2007 in your FAQs, and I'm just confused about the time. Could you just clarify that?
So it was adopted in so the current compact was adopted in 1960, and it's been in effect for over 50 years. Can you point, which other FAQ question were you referring to? Because
Number 2, as early as July 1st, 2007, or upon passage by 35 states, whichever is later.
I think that's an old, you're looking at the FAQ sheet?
Yes, I am.
Oh, okay, sorry, I was going back to my presentation.
No, that's okay.
So, I do believe that document is old. That was created by the AAICPC Secretariat's office. And so that this new compact we've been trying to have it passed since 2007. So,
A long haul.
It has been a long haul. And so really the timeline is that the first 35 states need to adopt the new compact. And then it is anticipated that we'll need 12 months to create the rules for the new compact. And then once the rule making is done, then the new compact would go into effect. So, so there's not a specific timeline because we need 35 states to adopt this.
Right. Okay. Then also in your FAQs, there's one about the cost, and there's a $500,000 estimated. I'm guessing that number is old as well. And is that a total cost? That's not cost per state, is it?
That is not cost per state. That is a total cost. So right now, each state we currently pay dues to both compacts that we are part of. So, and I can get you the figures as to what we pay for each compact. It would be an increase, and it would also be an increase in service of what we're getting. So right now, we need that good foundation, and that $500,000 cost would be spread across the country. And there is an algorithm, a formula that's made that each state doesn't pay the same amount. It's really based on the size of the state, the population, and the usage of the compact. And so,
okay. But this year there wouldn't be a budget increase this year.
Correct. The budget increase would happen at the time of the adoption.
Great. Okay. And then one final question. The last time last year we did the nurses compact, and we were, the language is just what the language is. We're basically not allowed to change it. Is that the same in this case as well?
Correct. The only way this works is that if every state adopts the same language for the articles of organization.
And you've been through S72 with a fine-tooth comb to make sure it's the correct language?
I have. And the one thing that I'll say is that's different here in Vermont is that we added on a subchapter 2 to our bill, which is the rest of the country will not be adopting. That is a Vermont version. In our current statute, we have a subchapter 2 that created additional due process rights for non-delinquent youth. So children who are part of child protection, who are court involved in DCF custody, they are awarded due process rights when we're looking to place them in out-of-state residential programs. And so those same protections we wanted to apply to have happen with the new compact as well.
Okay, great. Thank you.
Mm-hmm.
Okay, other questions? Okay, well, this is our first look at this, and thank you for the time that you've taken. If there's a way to update the FAQs, that would be great.
I can make that request of the national office.
Yeah, you probably, yes, because if every state is going to be going through this, it'd be great to have the same database to begin with. The other thing is we will go through this another time with our ledge council. We have not yet done that, but I think you're the expert in our midst, so this is very helpful. Other questions, committee? All right, Senator Hooker.
Thank you, Ms. Casanova. And I'm curious to know, what would prompt a state to apply to get involved here? I mean, we're looking at waiting for 35 states. I mean, who's pushing for this to happen in a timely fashion?
So the chief justices were sent those letters out to all the governors, and the New England Opioid Initiative, they sent it out to all the governors in the New England. And then it's really been up to the compact administrators in each state to try to persuade their legislator to adopt the new compact. I know that the private adoption attorneys, the Quad A attorneys, that they have supported it. And I know that in some states, they have been helping support the pushing of the new compact. It is a topic that comes up at every single annual business meeting as leaders in ICPC as to how we can help promote the passage of the new compact. So the COVID has really made it challenging because that has had to be the priority. And so there hasn't been as many opportunities for compact administrators across the country to take this on right now.
Yeah, thank you for that. And I do know that our Supreme Court Chief Justice is very much involved in these issues, in particular children's mental health issues. So we'll hear more about that probably in the spring. Okay, thank you. I think we're going to have to switch now. This has gotten to be very engaging and interesting to us, and we will pick it up again. So I greatly appreciate your being here, and also Deputy Commissioner Radke, thank you for joining us. We're going to move on at this point. So thanks.
Thank
Thank
you.
you.
Okay. Josh, welcome. Senator Terenzini, welcome. Glad you're here. Just an update for you, Senator. We did vote on H654 yesterday, just wanting to get that moving to the governor's desk as quickly as we could, but we haven't voted anything else. So just that's FYI for you.
Thank you. And I would have voted yes for it.
I know you would. That's great. Okay. All right. So we have with us Jen Carby on S285. The S285 is a committee bill. We had gone through some consultant reports, one from the task force on affordable, accessible healthcare. We also heard from Donna Kinzer, who was a consultant for Health Reform Oversight Committee. We also heard from the Green Mountain Care Board, and we also have looked at the financial sustainability report with regard to our hospitals. So we had chosen as a committee to look at moderate needs group and the blueprint and some language there. So as we discussed, and as I went forward and met with Jen Carby, Nolan Langwell, and Donna Kinzer in particular, and others to bring forward a recommendation in S285 that we can go through today with Jen. I know there'll be questions, and so we'll go through it with Jen. We'll try to understand what's there. I hope that each of you has had an opportunity to read it. I think after reading it a couple or three times, it begins to
Lorraine Siciliano joined the meeting.
It begins to gel. Good morning, Lorraine. I don't know how to do that on mine. That would be fun. Okay. So, Jen, thanks for being here. I know that your time limited and compressed because of where we are, but why don't we look at S285 and go through that language?
Great. For the record, Jennifer Carby, Office of Legislative Counsel. Do you want me to put the language up on the screen to walk
Yes,
through it?
I think that helps. I do. Yep. Everybody then is on the same page.
Make sure I'm sharing the right document. Okay. Hopefully you can all now see this as strike all amendment draft 1.2. So this was S285. The underlying bill is the one that you had introduced as a committee bill, but really with placeholder language, just expressing some intent to address the blueprint and access to home and community-based services. That was the moderate needs group. So this would be a strike all amendment, and it would put in a number of new provisions. The first group dealing with payment and delivery system reform. And so this is based in part on the Green Mountain Care Board proposal. This would appropriate $1.4 million to the board in FY23 to engage one or more consultants to assist the board to develop a process for establishing and distributing global payments from all payers to Vermont hospitals that would help move the hospitals away from fee-for-service and provide them with predictable, sustainable funding that is sufficient to enable the hospitals to deliver high quality, affordable healthcare services to patients. So that's the first thing, is to develop the process for establishing and distributing global hospital payments. Second, determine how best to incorporate hospital global payments into the board's hospital budget review, ACO certification and budget review, and other regulatory processes. And build on the board's existing work on healthcare data collection and analysis through VCures and the healthcare expenditure analysis by performing per capita benchmarking analysis by hospital service area and by cost category, and providing meaningful comparisons to spending levels for the same services in other US states and regions. So that also incorporates some of the recommendations from Donna Kinzer. So that's the 1.4 million. Then it would also appropriate 600,000 to the board to support the board and the Director of Healthcare Reform in the Agency of Human Services in the design and development of a proposed agreement with CMMI, the Federal Centers for Medicare and Medicaid Innovation, to include Medicare in the hospital global payments described in subsection A. So that's the 2 million then that the Green Mountain Care Board had requested, but including also some data collection and benchmarking work as part of that. And this would have, by September 1st, the Green Mountain Care Board provide an update on its use of the funds to the Health Reform Oversight Committee. And then by January 15th of 2023, the board would report on its use of the funds and the status of its efforts to obtain Medicare participation in hospital global payments to House Healthcare, this committee, and the Finance Committee. So that was kind of the payment and data collection, one of the data collection pieces in section 1. Section 2 is looking at the delivery system transformation and additional data collection and analysis. This would appropriate $3 million to the Green Mountain Care Board in FY23 to engage one or more consultants to assist the board, first in facilitating a patient-focused, community-inclusive redesign of Vermont's healthcare system to reduce inefficiencies, lower costs, improve population health outcomes, and increase access to essential services, including both providing the analytics to support delivery system transformation and leading the regional stakeholder community engagement process, and supporting hospitals and communities with change management following the redesign. So that comes from the Green Mountain Care Board's proposal. And then also using the funds to enhance the state's data collection and analysis by connecting clinical and claims data through an enterprise master patient index that collects data while preserving and protecting confidentiality of individually identifiable patient information, including determining how best to first optimize coordination and alignment of that enterprise master patient index with VCures and the Vermont Health Information Exchange in using the data on patient care and outcomes to inform the work of the blueprint in collaboration with the director of the blueprint and the director of healthcare reform. So informing the work of the blueprint, the state health information plan that's adopted by the Agency of Human Services, and the interactive price transparency dashboard developed by the board, Green Mountain Care Board, and finally to detect potentially avoidable healthcare utilization and low value care and identify additional opportunities to use the data for quality improvement and cost containment initiatives. These are some of the proposals from Donna Kinzer and others. Again, this would have, by September 1st, the Green Mountain Care Board provide an update to the Health Reform Oversight Committee. And then by January 15th of 2023, the board reporting on the use of its funds, its use of the funds appropriated in this section, including the status of the delivery system transformation process and efforts to improve the state's healthcare data collection and analysis to the same committees as earlier, this committee, Finance Committee, and House Healthcare. So that was the payment and delivery system reform provisions. Then we move into a new group of sections on the blueprint for health. So the first one here would amend an existing blueprint statute to add to the blueprint's initiatives the use of quality improvement facilitators, which is something the blueprint already has, but is not specified in statute, and other means to support quality improvement activities, including using clinical and claims data to evaluate patient outcomes. So tying back into that Enterprise Master Patient Index language in the previous section, and promoting best practices regarding patient referrals and care distribution between primary and specialty care. And this is one of the recommendations that came out of the hospital wait times report that just came out last week. Section 4 would specify an increase, although it doesn't specify yet, it puts in placeholder for you to determine the appropriate increase to the per person per month payments that go through the blueprint to medical practices for contributions to the shared costs of operating the Blueprint for Health community health teams, which is currently reflected in the blueprint statute, and quality improvement facilitators, which are not. The increase would also apply to Medicare to the extent permitted by CMS. And then this would appropriate a sum of some amount that goes along with that increase to the per person per month payment and global commitment dollars to DVA in FY23 for the Vermont Medicaid portion of the increased blueprint payments. And if CMS does not allow federal financial participation for the increase, then it would be done with state dollars only and would direct the department to reconcile the difference in its FY23 budget adjustment proposal. Then we move into some options for extending moderate needs supports. And so this would create a working group, but also infuse these concepts into the next global commitment waiver. This would direct the Department of Disabilities, Aging and Independent Living, DAIL, to convene a working group comprising representatives of older Vermonters, home and community-based service providers, the Office of the Long-Term Care Ombudsman, the Office of the Healthcare Advocate, the Agency of Human Services, and other interested stakeholders to consider issues related to and develop recommendations for extending access to long-term home and community-based services and supports to a broader cohort of Vermonters who would benefit from assistance with one or more activities of daily living and their family caregivers. And so they would be looking at issues including the types of services such as those addressing activities of daily living, falls prevention, social isolation, medication management, and case management that many older Vermonters need, but for which many older Vermonters may not be financially eligible or that are not covered under many standard health insurance plans. The most promising opportunities to extend supports to additional Vermonters, such as expanding the use of flexible funding options that enable beneficiaries and their families to manage their own services and caregivers within a defined budget, and allowing case management to be provided to beneficiaries who do not require other services. How to set clinical and financial eligibility criteria for the extended supports, including ways to avoid requiring applicants to spend down their assets in order to qualify. How to fund the extended supports, including identifying the options with the greatest potential for federal financial participation. How to proactively identify Vermonters across all payers who have the greatest need for extended supports, and how best to support family caregivers, such as through training, respite, home modifications, payments for services, and other methods. It would direct DAIL to collaborate with others in the Agency of Human Services as needed in order to incorporate the working group's recommendations into the agency's proposals to and negotiations with CMS for the next iteration of the global commitment waiver, so that the extended moderate needs supports can be available to Vermonters beginning on January 1st, 2023, which is when the next global commitment demonstration should be in effect. And on or before January 15th of 2023, the department would report to a number of committees, including this committee, House Human Services, House Healthcare, House Appropriations, and Senate Appropriations, with the working group's findings and recommendations, including the portions of the recommendations that were incorporated into the new global commitment demonstration and the amounts of any associated funding needs. Getting close to the end, next we have the summaries of Green Mountain Care Board reports. So this would add to an existing provision in statute on the duties of the Green Mountain Care Board, that the board summarize and synthesize the key findings and recommendations from all reports prepared both by and for the board, including its expenditure analyses and focused studies. This had been a recommendation from Donna Kinzer, and this would make all reports and those summaries prepared by the board available to the public and posted on their website. Finally, the act would take effect on passage, although you could change that. And I just noted that you would likely want to update the title of the bill to reflect what is ultimately in it. Take that down
Okay.
and stop time.
So questions, committee? Go ahead, Senator Hardy, go ahead.
I always try to hesitate, so I'm not the first
It's
one to
okay.
ask a question, but
Good.
Cheryl, Ann, anything? Sorry, question about the blueprint part of the bill. Does the payments there they're vague? So is it just for anything that they're doing? Or is it for a specific I know they have a bunch of sub programs.
Right. So the language that is in existing statute talks about supporting, I believe, supporting specifically the community health teams.
Right.
So I expanded the language to include the quality improvement facilitators, but I don't know. I think there's also appropriations that come or funding that comes outside of the per person per month. Those are really the payments to the practices.
Okay. I just wonder if it covers, and maybe Josh knows this, covers the stuff they do with both the MAT and, the
Hub and
opioid
spoke.
hub and spoke,
It would be, yeah.
the diabetes work that they're now doing,
Yeah.
all the many different
Yeah.
programs they're doing, or if it's for a specific one. It's unclear to me.
I think it's general overall. So
Josh, do you have an answer? Do you know?
So there, I'm not sure of the dollar flows from the state to the practice. So I'm not certain how the community health teams are paid. I believe they all get state checks. And so I'm not sure, I don't know the answer to the question. We need to ask the department how those dollars actually flow.
Okay. Yeah,
I think it would be
just
important to
helpful.
find out, from AHS likely, how they fund the individual initiatives within the Blueprint for Health.
Okay.
Is that really the question? Is how do the per person per month payments to the practices relate to all of the various Blueprint initiatives?
Exactly.
Yeah,
And whether
and-
they're new stuff, because I know, for example, they just, the diabetes work they're doing is relatively new. So I wouldn't want that to be left out. And one of the things that we're hearing, obviously, right now is that the hub and spoke work is even more important than ever. And so I wouldn't want that. Anyway, I just want to know what the money's for. And then in the section about the moderate needs supports, one thing that we heard pretty clearly from the people who came in and testified was the need to reorganize their wait list to make sure it was reflective of the highest needs, moderate needs, the highest moderate needs. And I didn't, maybe this is in here, Jen, but I didn't see that as part of it, like reorganizing the.
It's not
Adjusting-
specifically in here. I think there, I think that was reflected in the conversation about the existing Choices for Care program, because this is looking to kind of expand the universe of people services and funding. I don't know what that would necessarily look like, or whether there would be prioritization or wait lists in the future. We can certainly look at adding something reflective of that. I'm just not sure exactly how to reflect that.
Would that, it might go in that introductory statement in A somehow, because they're currently doing that. We could just say in addition to looking at, because I think Senator Hardy is right that is something that they're doing that we probably should reference.
Yeah, I just, as we're expanding the number of things that they're doing, I don't want them to not serve the highest needs people with moderate needs.
The highest moderate needs.
The highest moderate needs. So that
Yeah.
was just, and also just one more thing on this section, it's the timeline seems pretty tight given how overwhelmed they are. I mean, I know it's sort of in conjunction with the global commitment re-up, but it's a lot for them to do in a short amount of time. But
it's just an update. I think it was just in a matter of looking at how organized, what their organizational structure was. But, at that point, I don't think we would expect any robust report, but
okay.
Yeah.
And then I just assume we're going to have the Green Mountain Care Board in to comment on this.
Oh, yeah.
Okay. I just want to make sure that the first part works for them as well. So.
Yes. Yeah, we should. We'll reach out. I think, Jen, if you can reach out to Diva about the initial question on the reimbursement or not on Diva, AHS, whomever.
Yep.
Yeah.
I think I'll start with Ina.
Yes, I was thinking that. And then, and we did meet with Ina. I did meet with Ina and others on this, but this is the first framework. So it's important to get some of the details. This is good. Okay.
Yeah, and I would just like to hear from Green Mountain Care Board. I got a note from Jessica Holmes this morning, so I just want to make sure they get a chance to come in about the language. So.
Yes, absolutely. We'll do that.
Thanks.
That everything they asked for, we've modified some of the things they've asked for, understanding that we also looked at Donna Kinzer's report. So it's hard to have two masters, but that's what we're trying to do. Maybe 3 or 4, 5 or 600. Senator Cummings.
Yeah, I would like to hear from the home health agencies.
Okay.
I've gotten an email from my local one and they're losing money hand over fist at this point. So have some real concerns about expanding the responsibility.
Well, I think what the bill does is it asks for an analysis of what is possible, and which is why we didn't put in an expansion. But we can bring those folks in. That's a perfectly good idea.
Would be helpful.
All right. Anything else? That would be Jill Olson, probably, and maybe Laura Pelosi. That's nursing home. So
I'm thinking home health.
You want home health. Yeah.
Yeah. That's where this is going to land.
Yeah. Do you have a suggestion of someone you'd like to hear from?
You could try Central Vermont Home Health and Hospice, Sandy Rouse.
Okay.
But I don't know if they have
they may not have, they might not have the global, but
they may. I think they have a lobbyist, the whole organization.
Jill Olson is the
Jill.
Yeah, that's what I thought.
That's why I mentioned her.
You could.
We'll bring Jill in and she may suggest some additional testimony.
Yeah.
All right. Any other questions, comments? Okay. Wow. Okay. So Josh Slen is here. Do you have any questions for Josh, or Josh, do you want to make any specific comments in the blueprint moderate needs area? If we tried to use at least some of the information that you provided to us, and last time we went through, you may have had some concerns, so I'm just asking for your thoughts here.
No, I appreciate that, and I'm happy to be constructive in this conversation here. With the reservation that I would like to read through this a second time, because we went through it quite quickly and there's a lot in there. And it's all connected, as we know, right? So each piece is connected. But what I would say is that on Senator Hardy's comment regarding the moderate needs group and the prioritization exercise that the department has said they are going through now. My administrative experience would say that it is helpful to have some language that recognizes that it's a priority to have prioritization, and then let the department come back and do that. So I would support that. I think that's a good thing to do. Because once you start doing that prioritization, actually, it's good to have legislative language behind you that says you have to do it, because it gets thorny when you actually start prioritizing, right? So that's why I say it that way. And then I would say for the blueprint that really that fund flow is important, but recognize that any dollars that get given to a primary care entity are fungible once they hit that entity. So there's substitution that can occur. So that's just.
So you're just saying, don't get too specific, but we don't want to be too unspecific. So it's got.
Well, I think we go in two different directions here, right? One is to say you can only use this money for this very specific thing, and that's pigeonholes it and requires lots of reporting. And the other is just here's dollars for the primary care facility. I think actually, given where we are in workforce, and given where the blueprint is, that discussion about how to target it is one that should be had after the fund flow is discussed, with the blueprint about how to best put this money to use so it doesn't just be absorbed without going, specifically where you want it to go, and with the least amount of administrative burden on the providers. So I think everyone can support that generally, but it's good to have that explicit conversation so we don't pump money into the primary care practice and it goes somewhere you didn't intend it to. So that's one other comment. And then I am very interested and look forward to hearing Jill's comments on the home health agencies and how that rolls out. And then finally, my last comment that may be helpful is for the moment is that the question about timing and how fast the Department of Aging and Independent Living could move forward and do some of the moderate needs changes. I think that regardless of the amount of effort necessary, the conversation with our federal partners happening, and so that has to proceed. The implementation could be pushed out, but the actual global commitment submission, this has to go in that whenever it goes in, right? So I guess my point would be we should be clear, if we can, in the legislative language that it needs to be in this version of the global commitment, not miss that train, right? And then after that, the actual administrative thing could be delayed by a quarter or something, right? The actual implementation might be delayed because we get backed up, but the submission needs to happen, and this should be in it. So I think we could be a little more, we could point at that issue in the language a little bit.
Okay, that's helpful. May as well be specific. All right, any questions for Joshua? Okay. Jen, are you still there? And Nolan? So in terms of the quadruple X's that we have in the blueprint section, then we'll have to sort out what exactly goes in there. I'm trying to think through what goes there, what might better be there, but and maybe Nolan, or but as we hear from AHS, that may help clarify. Okay, so we'll hold that thought until that time.
Right, I think you need to
yeah.
identify what the additional funding need is, so you can back into the amount of the per person per month payment. And then that will inform the amount that needs to be appropriated as well. So I think until we have a better sense for what the need is,
Okay,
we won't know how much to increase it.
Yeah, and
Okay.
for the record, Nolan Langwell, Joint Fiscal Office, I also think that it would be important to hear from Ina, particularly because Blueprint is an integral part of the global commitment waiver negotiations.
Right.
And so our ability to increase payments may be tied to whether we even can use Blueprint's always a part of the negotiation. So that's going to play into that piece as well.
right. Well, if this is the hard piece, because we've always advocated for primary care as prevention and trying to, we don't want to rearrange deck chairs necessarily. What we would like to do is to invest more fully in primary care as prevention, and then get savings at the other end. And those are the savings that we'd like to invest. But initially, you need to have a resource investment to make it happen. So it gets catch 22-ish. Go ahead, Senator Hardy.
Thank you. Just in going through the language a little bit more, this section on page 2, paragraph B, the $600,000 to Green Mountain Care Board, in the design and development of the agreement with CMS. What do they do versus AHS in that agreement renegotiation? Do you know, Jen or Nolan or Josh?
I mean, I think it's definitely a partnership. They were both signatories on the original version. I think there is my understanding that it's important to the federal government that they're both signatories going forward. So the funding is appropriated to the board, but it's to support the board and AHS. I think they would need to tell you what their specific roles have been in the past and what they see going forward.
Okay. Oh, I see. It says the board and the director of healthcare reform in AHS in the design.
Right. Yeah.
Okay, so it's for both of them. That because I thought it was a partnership, so I didn't want to I wanted to make sure AHS was not left out, but I see that it's there. The second question or comment on page 3, this is the stuff about the community engagement. I guess I would really like to double down on making sure that we have a really good community engagement process as we're talking about how to redesign or, alter things in our hospitals, because so it says community inclusive redesign, but I think it would be important to have in there language specific about community engagement with actual people or
So are you, Senator, let's go through it together, because you're that's a whole section that begins on number 1, and then you're going through with the communities that B, A and B, and then 2. So that's Jen, walk us through that, because this is a really important point that's being made about making sure that people are fully engaged. And it isn't just we're not just talking about hospital administrators here.
exactly.
We're talking about everybody who's in this healthcare world. So how can we put language in that really suggests you're talking about having a really robust community engagement process?
Yeah, I mean, just having been through the Act 46 process, I just know that this is not exactly the same, but it's kind of similar in some ways. And we want to make sure that people know what's happening. And it's not just the hospital administrators who know what's happening. That's actual people in the community. And I guess I would also, include the healthcare advocate in this process too, so that there's really somebody at the table who's paying attention to how this will impact patients or consumers, as some people like to call them, but the people who are using the healthcare.
This is, yeah, so that's a good point to be made. And so let's think about how best to do that. I see Jen is taking notes on this. This is important. And I think this is a real key part of any transformation that's going to take place, because if people can't work together, it isn't going to happen. So when we have the Green Mountain Care Board in, we'll have to follow up as we're looking perhaps at some new language that modifies this. We'll have to have them in and follow up. Okay. Anything else, committee folks, at this time? Do you want to go quickly through the bill one more time? Not at the 2-foot level, but maybe let's go a little bit at a slightly higher level that will help reinforce what's here. And then it may raise some questions for Jen as we're going through. So why don't we do that? I think that's, repetition is not a bad thing.
Okay.
Yeah, let's do it.
Put it back up. Whoops. All right. So the first section then is the 1.4 million to the board to engage consultants around hospital global budgets, incorporating them into the board's regulatory processes, and building on the board's existing healthcare data collection analysis work through VCures and the expenditure analysis by doing per capita benchmarking analysis so that there can be comparisons to other states and regions in the US. That's the 1.4 million, and then 600,000 for the board and AHS to design and develop a proposed agreement with CMS or CMMI in this case, to include Medicare and the global hospital payments. And then reports due September 1st, 2022 and January 15th, 2023.
And just to reiterate that early 2022 is just to let us know that things have started. So.
Right, it's really an update.
It's an update.
Section 2 is the $3 million to the Green Mountain Care Board for consultants for facilitating the patient-focused community inclusive redesign of the delivery system and supporting hospitals and communities with change management, and also to enhance the state's data collection and analysis by using this enterprise master patient index and figuring out how to coordinate and align that with VCures, the Vermont Health Information Exchange, the work of the Blueprint, the State Health Improvement Plan, the Interactive Price Transparency Dashboard, and use the data to look for ways to identify potentially avoidable healthcare utilization in low value care and other ways to use that data. And again, reports due September 1st and January 15th. Sections 3 and 4 are on the Blueprint. The first one about using kind of codifying this idea of the quality improvement facilitators and other ways to support quality improvement activities. And section 4 being some increase to the per person per month payments to medical practices, both for community health teams and quality improvement facilitators, and looking to get federal participation and also appropriating some amount as needed for the Medicaid portion of that.
I don't mean to interrupt the flow here, but I just like to make a comment that every time we hear about the Blueprint, regardless of whether it's from someone locally or someone more at a national level, including our consultants, we hear that the Blueprint is an outstanding, nationally known program. And so that it might not receive a blessing from CMMI would be, I couldn't understand why it wouldn't. So anyway, keep going.
Any?
Yes.
Just, I'm looking at all the millions that we're appropriating.
Yep.
Is this in the House budget?
I don't know.
Okay, does
I have talked.
appropriations know it's coming?
Yeah, I've talked with Senator Kitchell, and I'm going to talk
Okay.
with her again. And we don't know what will happen to it in appropriations, but I do know there is some interest in having this go forward. So we'll continue
Okay,
it.
I just wanted to make sure, because I've
Yeah,
been
no,
told I have to get out some tax bills because all the money is spent.
yes, I'm sure it is.
So I just checking.
I do know that the BAA had money in it for some of this. So
Okay.
Okay, section 5 is looking at options for extending moderate needs support. So having Dale convene a working group to look at issues and come up with recommendations to extend access to home and community-based services and supports for more Vermonters. Having them look at the types of services, most promising opportunities to extend supports, including things like expanding use of flexible funding and allowing case management only. Setting criteria for the supports, how to fund them, identifying Vermonters who have the greatest need, and supporting family caregivers. And this would have Dale collaborating with others in AHS to incorporate the recommendations into the next global commitment demonstration so that these supports would be available beginning on January 1st, 2023, which is when the next demonstration should be taking effect. We're in a 1-year extension right now, and having a report back on January 15th of 2023 on that. Then we have the requirement that the Vermont Care Board summarize and synthesize the key findings and recommendations from its reports, the effective date, and the placeholder for a title change.
oh, we forgot the title. Okay.
Well, I think once you have decided what's in the bill, we can make the title reflect what's in the bill.
Okay, we're good. Good idea. Okay. That's it for now, I guess. Thank you. Any questions, committee, at this point? So we have some folks we'd like to have in on this, not the least of which are Green Mountain Care Board, the Healthcare Reform Director, and Home Health. Those are the ones we've been looking at most specifically. So we'll have them come in. We'll see what we can do about getting them in sooner than later.
Maybe also the healthcare advocate to see where.
Yeah, I got him on the list too.
Certain-
Thanks. Yep.
Yeah.
Yeah.
Thanks. Thank you, Jen and Josh.
I will say,
The judge.
let me just say, there are a lot of interested parties who will want to comment on the bill. We've already taken a lot of testimony from a lot of different interested parties, whether it's Dale or whether it's individuals with concerns about access. I think our goal here is to listen to the folks that we've identified and then try to move the bill before crossover. So that it's going to be hard to have miles and miles and hours of testimony at this point. We've already heard a great deal from many people, whether it's been in the task force process, HROC process, the healthcare committee, health and welfare committee, appropriations. Everyone's been taking testimony on this and listening. So that's it. Okay. So it is 9:49. We are going to take a little break off YouTube briefly. Let's take a break for about 5-10 minutes.